Go ahead.
Perfect. Good evening, everyone. Thank you for joining us today on the 22nd Arab
You are muted. You are muted.
Association. Am I muted? Can you hear me? Perfect.
Yes.
Good evening, everyone. Thank you for joining us today on the 22nd Arab Public Health Association webinar. Thank you, Professor Salman Rawaf, Professor Tawfik, Khoja, and colleagues for having us today. Today, we will be discussing nutrition and the pandemic. As we know, during these tough times, this topic has been a great concern for healthcare professionals and the general public. The media even enjoyed spreading information over the past few months, whether true or not, about supplementation, exercise, clinical recommendations, and so on. We do have many areas to cover today with 3 speakers. From Imperial College London, Federica Amati, who is a public health nutritionist, who will be tackling the known associations of nutritional status and COVID-19 in her talk today as our first speaker. Our second speaker is Dr. Ayoub Jawaldeh, who is a regional advisor in nutrition at WHO in the Eastern Mediterranean region, and will be talking about the integration of nutrition care and in healthcare systems to cope with COVID-19. The third speaker will be myself. My name is Celine Tabche. I'm a registered Associate Nutritionist and a PhD candidate in public health at Imperial. And the topic that I will be presenting is the role of clinical nutrition in COVID-19. We will start with Federica. The floor is yours.
Thank you, Celine, and thank you very much for this opportunity to present today. I will just share my slides with you all. Let me know if you can see them okay. Perfect. So I'd like to start by giving a little bit of a forward, just to say that pandemic preparedness has been on the global health agenda for a while. And in my talk today, I'd like to focus on what are the opportunities that we have now. We all know the challenges that we're facing, but what opportunities do we have to integrate nutrition within our health systems and to make nutrition a universally available priority? The importance of using evidence-based policies to drive government interventions and to actively combat scientific misinformation and really engage the public to evidence-based benefits that they can benefit from themselves with better diet, physical activity, and improved health outcomes. I'll start by briefly touching on the Global Nutrition Report from this year. Then I will focus on the current malnutrition crisis and how that impacts COVID infections and outcomes. What the relationship is between COVID-19 and metabolic disease and what the evidence we have from the most recent reviews are. And then how we can insert nutrition into a roadmap to improve immediate health outcomes, but also in the long term to reach our global health goals. So I'm sure that many of you will have seen the Global Nutrition Report from this year, which states that poor diets are among the leading health and societal challenges. We know that nutritional imbalance is the #1 contributor to the leading causes of death globally. And in the context of COVID, good nutrition is essential for an individual's defense against coronavirus, and nutritional resilience at a population level is a key factor for society's readiness. We know that those countries that had higher food poverty are really struggling now that COVID has hit. It's highlighted the nutrition inequities and how it impacts those who are more deprived and have less access to nutritional food. And it's something that we really should focus on in public health space. So with metabolic disease, we know that COVID does not treat us equally. Age is a number, which is very important with this pandemic, but it really masks the underlying causes of it, terrible outcomes, mostly from metabolic diseases. We know that undernourished people have weaker immune systems and lack macronutrients. My colleague Celine will touch on that in deeper. But poor metabolic health, including obesity and diabetes, is strongly linked not only with an increased risk of infection from COVID-19, but also outcomes, including hospitalization, needed to be intubated, and also ultimately death. Unfortunately, at the moment, most people cannot access or afford quality nutrition care for preventative treatment, which is being made worse by the poverty which COVID has brought due to job loss and disruption. The global metabolic disease trends from the report also highlight the fact that no countries are on course for the reduction in obesity that we're trying to achieve, and a handful of countries are doing some positive work to tackle diabetes. So it's something that affects absolutely everybody in every region. So we know that from the CDC that cardiovascular disease and diabetes are particularly bad underlying causes when we're looking at COVID patients. In a meta-analysis of clinical cases, patients with a BMI above 25 had a much increased odds ratio for need for additional respiratory support, but also for death. So if we take a look at obesity specifically, we think that the impaired immunity comes from altered cytokine response, which usually have a key antiviral role. And interestingly, the ACE2 receptors, which we know coronavirus links to preferentially, is basically abundant in adipose cells. So the level of expression of ACE2 is much higher in obese patients, which goes some way in answering why they're so susceptible to the disease and to complications. These two studies are brilliant. They basically give us some very hard numbers to look at on a large population studies that show us that both diabetes and obesity have a much increased hazard risk of death for patients who contract the virus. But also, if we look at the obesity study, it actually tells us that not only is it an increased risk of death, but actually increased risk of being COVID-19 positive, hospitalization, ICU admission, and ultimately mortality. And over on the right-hand side, we can see that patients with type 2 diabetes have an increased risk of death. And patients with type 2 diabetes whose BMIs are either below 20, so very undernourished, or higher, above 25, have a higher hazard risk of death. This graph from the Lancet shows us that that diabetes really increases the deaths per 100,000. So the rate is really increased in patients with diabetes, and it's something that we need to try and address. Luckily, there is something that seems to help. By regulating hyperglycemia, we can see that COVID-19 patients actually have improved outcomes. So in one study, hospitalized patients that had hyperglycemia were given insulin infusions, and this actually reduced their inflammatory mediators and reduced their risk of death. So there is some hope in being able to help these patients. The question is the answer diet and physical activity in the prevention of COVID-19? So of course, by improving access to whole foods, fruits and vegetables specifically, we are going to help the population move towards a healthy BMI. We can improve the intestinal microbiome, which is important, absolutely crucial for the role for immune response. Improve micronutrient status, which is very important for recovery from COVID as well as prevention. And by focusing our efforts in improving this access to a nutritious diet now in the context of COVID, we are moving the process of change forward, because when we speak to our patients, it's more difficult to engage with them to prevent something that might happen to them in 20 years' time. But when you are talking about something that might impact them next week, it is, it's a lot more tangible. And I think it's important for us as public health professionals, but as medical professionals and interested peoples, to realize that access to this food is a key part of patients being able to achieve this. So inserting nutrition into the roadmap to prevention for COVID and to improve outcomes for patients who do get COVID, we have to remember that the cumulative risk of COVID mortality increases with obesity-associated chronic diseases. Nutrition plays a major role in not only preventing obesity, but also in preventing the complications from COVID in this population. So by focusing on nutritional well-being, we provide opportunities for establishing synergies between public health and equity. And my call to arms would be to put nutrition care as a crucial part of a wider package for primary healthcare and universal health coverage. All of this without forgetting the social determinants of health, which play an absolutely crucial role in this. We know that obesity is not a personal choice. It is not something that patients can just decide not to be. So we're within the context of providing a choice for healthy food and providing access to a healthful diet, we have to remember that there are baseline discriminations which disadvantage populations. And that is why in previous slides, the index of multiple deprivation is also a very highly associated risk factor for COVID outcomes. So where social determinants of health impact obesity, they impact the severity of the outcome for COVID and the chronic diseases associated with that. In conclusion, in this whistle-stop tour of public health nutrition for COVID, we know that obesity and diabetes are major risk factors. We know that we are trying to reverse the global trend in obesity and diabetes, and the need for more equitable, resilient, and sustainable foods, access to foods, is important, and it's even more urgent now. As the Global Nutrition Report highlighted, we need to try and integrate what we know into our interventions, including the emergency interventions being put in place for COVID now, to reduce healthcare spending and in the long term ensure that nobody is left behind. Thank you very much for listening.
Thank you very much, Federica, for a very informative presentation. So now I'm going to introduce Dr. Ayoub again, that he will be talking about the integration of nutrition care into the health systems. Dr. Ayoub?
Good evening. I will just try to, can you share my presentation? Yeah, from your end?
Sure. Chido, if you can.
Yeah. Good evening, everybody. I'm very pleased to join you in this important webinar. And in fact, nutrition, as you know, is top priority in order to address the prevention, as my colleague indicated. So in my presentation, I'm going to highlight the integration of nutrition care, preventive and curative in health system in Eastern Mediterranean region to cope with COVID-19. And as you know, the World Health Organization Regional Office in Egypt trying to provide member states with different aspects to cope with COVID-19. Therefore, I'm trying to highlight some intervention at policy level. But before that, I would like just to highlight the malnutrition in all its forms take a heavy toll of the health and well-being. And also some countries, especially those affected by conflict, continue to experience high level of food insecurity, undernutrition, and micronutrient deficiencies. We have about 20% million children under 5 age stunted and poor in nutrition. And also 50% of women, or more than 40% of men, they are suffering from malnutrition. Non-communicable disease is also another challenge related to unhealthy diet. More than 50%, as we said, of women suffering from obesity. Next. Yeah. As you see here, globally, of course, we have 24 million people affected by food insecurity and malnutrition in 8 countries. And among those 8 countries, 3 countries from our region, like Yemen, Syria, and Afghanistan. And also, if you look at the total people affected by undernutrition, we have in Middle East and North Africa about 43 million. Next. As I said earlier, the impact of COVID-19, it has an impact in all countries. But if you look at the low-income countries, and we have among of the top 8 countries globally, 3 countries from our region, they are suffering from the crisis, and because of COVID-19, the situation has been worsened. Next. Yeah, I'll give you example how COVID affected those countries. For example, in 27 countries, we have 9 countries affected on the food crisis in our region. In Afghanistan, for example, food prices has increased up to 20%. In Somalia, same thing, 20 to 30% the food prices, and affected their export, especially the livestock to neighboring countries. In Yemen, 35% increase in food prices. And as you can see, is in addition, of course, to the impact on increasing the unemployment, increasing the job opportunities for the youth, all these added more pressure on member states. Next. Of course, my colleague just talked about the global report published in 2020, but also there is a policy guidance on COVID-19 and food security and nutrition has been published, which is really a very rich document. In May 2020, in response to the crisis, the 4 regional directors in our region, WHO, WFP, UNICEF, FAO, they signed a policy statement supported by action plan to help the countries to set up priorities and also to help policymakers in order to go for better targeting. Next. As you can see here, really integration of food and nutrition throughout the health system is very important to ensure equity. And as you can see, nutrition inequity is very common in our region. You can see 1 in 9 people are suffering from undernutrition and 1 in 3 are suffering from obesity, especially when we talk about low income countries. Also high income countries at the same time, they need to have access to the healthy diet, also to have access to the knowledge and to advocacy in terms of healthy food. Next. Now, in nutrition equity, as we can see, it's an hour defining opportunity. Now, everyone should have access to healthy, affordable food. And for example, instead to subsidize bulky food like wheat flour or oil, even in poor country or high income country, I would go for subsidizing or supporting the public through offering fruits and vegetables or healthy school meals. Those kind of subsidy program, for example, if you review them, you will find there is a strong gap or in most of the countries. And still, even high income countries, they subsidize palm oil or sugar. So we have to change the way how to ensure nutrition equity. And also, as we said, the food system itself, it needs really to be linked with health systems so that we ensure the public have access to high quality food and healthy food. Next. Now, if you look at integration of nutrition within health system, we have 6 pillars for health system. If you look at leadership and governance, in most of the government, nutrition is lacking as top priority in the health system. While, for example, if you want to promote, for example, healthy food, you need to reduce salt in the food, or you need to reduce trans fatty acids. This is what you need, only legislation. And this legislation can be formulated at Ministry of Health. Also, the health workforce, still, we don't have really enough competent and qualified nutritionists pre-positioned through primary health care or hospital. You find strong, or there's a variation between countries to them. Some countries, they have really good workforce. Some countries, still they don't have. So we need to invest on the manpower. Also, the health system financing. If you look at the priority of the government, they maybe provide support to essential medicine. But if you look at, for example, micronutrient supplementation, this is key intervention. Look at within health financing, nutrition counseling, that really required support. And access to essential medicine, as we said, the infant milk, the infant and young child nutrition, they need to promote it, of course, breastfeeding, which is cost effective, but at the same time, pregnant mother, adolescent girls, we need to make sure that iron supplementation is there. So same thing with health service delivery at primary health care, we need a nutrition counseling. And we have good example in the region, like high income countries, they have really integrated nutrition counseling within the health system. Next. Here, when we talk about opportunities in health system, in fact, yes, we have universal health coverage. And now WHO and all member states, they are investing in universal health coverage. If we invest also in our region in universal health coverage, and we ensure the advocacy, we ensure the essential nutrition services and integration of nutrition services through primary health care, also through the essential package, that will really save lives of people and ensure access the public to the healthy diet. Next. Here, I would like to talk about build equitable resilience and sustainable food and health system, as well as invest in nutrition, especially among communities most affected by COVID-19. And as you see, nutrition care should be integrated and should be part of universal health coverage, and also an equity to sensitive approach through affordable food to the public, and well-resourced, well-coordinated and accountable resources to expand or to meet the needs of the targeted population. Those can be really put together through transforming the system. And we have a golden opportunity now that health system is going through a transformation in most of the countries. So we need a voice of the nutritionist or the public health nutritionist to encourage countries, member states to go for this direction. Next. Here, I will talk about health financing. I'll give you an example. We have just published a paper. In GCC, they added sin taxes, 50% on soft drinks and 100% in energy drinks. You know, there is a sharp reduction on the consumption of soft drinks in the region because of they added these sin taxes. So these sin taxes or those taxes can be used to support the health system or to address obesity in schools. So this is example how health finances can be useful tool to improve or to influence the healthy diet. Next. As you can see here, we have a good framework of action for food system developed for Oman. And in this framework, we have focused on food supply, food environment, and consumer behavior. So here we worked with all stakeholders with support of WHO, FAO, and UNICEF, and also all government institutions, NGOs involved in this developing a model. And in this model, we promoted, for example, the healthy diet through reducing salt, fat, sugar, promoting fish, fruits, and vegetables, as well as supporting breastfeeding. And this is a package supported by advocacy campaign. And this is a good example where all sectors can work together and can show a high impact. And the good things or the beauty, you know, Ministry of Health worked with Ministry of Agriculture, with the municipalities, with the environment, with the trade, industry. So all as a task force shows really high impact. Next. Now, this is another example in Yemen, low-income countries, countries under emergency, and here, how to cope with COVID-19. WHO worked with UNICEF and WFP, and we invested on supporting to suppress the transmission and also ensure that the transmission of COVID-19 within the health facility is minimized, especially for malnourished children who refer to the health clinic or mothers, and also invested on saving lives of children through therapeutic feeding, as well as try to ensure hygiene is there. And this is something really practical and shows that our intervention through suppress, supply, and save could work at all levels for different group of countries, whether high income or low income countries. Next. Now, we have, as I said, we developed a signed a policy statement by the foreign organization, and we helped countries to focus on cost-effective intervention, especially during COVID-19. The first one is to invest on feeding practices and behavior, breastfeeding, fortification of food, which ensure access of the public to the micronutrients, Micronutrient supplementation, we need to do supplementation to protect mothers from anemia, to strengthen the immune system, and also treatment of acute cases of malnutrition. But those interventions should go side by side with other sectors like promoting agriculture, fruits and vegetables, clean water sanitation, education, employment, and also support the healthcare and support the resilience. Next. In our region, we have developed a nutrition strategy, and this strategy is very comprehensive. So on this strategy, we focused on 6 or 7 pillars to help countries so that countries can really make sure the implementation, which really do help to protect the public and ensure healthy diet to address double burden of malnutrition, undernutrition and overnutrition. And this can be achieved through protecting nutrition in a crisis, reinforce food and nutrition surveillance, post-nutrition sensitive social protection, continue to place high priority on promoting maternal, infant, and young child nutrition, strengthen the health system, and also use public procurement as a tool to protect food security and nutrition, ensure access to and consumption of healthy diet integrated through different sectors. Next. So to summarize, before I end, we have been working through a partnership with all key stakeholders. We have very strong support from our management at all 3 levels, at global, regional, and country level. We work very closely with member states and with other UN agencies. And also here we should admit and thank the academia and research centers who are our right hand to generate more evidence. And we have right now in the regional office more than 10 consultants. We are trying to document all the outcome, all the experiences, and we are publishing a series of documents which we can share with you so that we make sure that lessons learned is there and also disseminating policy to all member states. Thank you very much for giving me this opportunity. Thank you.
Thank you very much, Dr. Ayoub, and thank you, Chido, for helping us. It's a very important topic, and it's a great segue to my topic next, which is the role of clinical nutrition. So I'm gonna share my screen now. I hope you can see it. Perfect. So I'm gonna be talking about the role of clinical nutrition and COVID-19. So I'm going to be talking about nutritional adequacy, so nutritional effectiveness and COVID-19. We're going to know how to identify malnutrition during COVID-19, clinical nutrition in the ICU and the intensive care unit, and general guidance at the end. So how does infection relate to nutritional effectiveness and COVID-19? So infection increases the metabolic demand for energy yielding substrates to facilitate the production of immune system cells and mediators. Primarily, these substrates are glucose, amino acids, and fatty acids that require vitamins and minerals as cofactors to be produced. So infection increases the requirement for key micronutrients to help support an adequate immune response mediators, such as nucleic acids, we need iron, folate, zinc, magnesium. For amino acids, we need vitamin B and sulfate. For gene expression, we need vitamin A, D, and folate. For antioxidant defense system, we need vitamin C, E, copper, iron, zinc, selenium, and magnesium. So what about malnutrition during COVID? So malnutrition is characterized by recurrent infections and chronic inflammation. So there's 2 types of malnutrition, undernutrition and overnutrition, but both have common etiological pathways, which is altered metabolism, chronic underlying inflammation, and gut dysfunction. Undernutrition is widely known why there might be a link with malnutrition, but why overnutrition? Overweight individuals tend to intake excess energy and macronutrients, which often coincides with micronutrient deficiencies. So some studies about macronutrients were firstly on children, where protein energy malnutrition, which results from deficiencies in any or all nutrients, is a common cause for immune dysfunction. Results in reductions in both innate and adaptive immune function, reducing T and B lymphocytes. And 2 other studies were done in the developed world, where malnutrition is often community acquired and associated with poor clinical outcomes. 23% of European older adults are at high risk of malnutrition. In UK, that figure is 29%. So obviously, malnutrition is associated with worse clinical outcomes in those admitted in secondary care because of impaired function due to impaired immune response to infection, which results in increased muscle depletion, increased frequency of complications, increased length of stay, morbidity, and mortality. What about obesity? Obesity can lead to reduced immune competence associated with increased susceptibility to a range of infections, delayed and weakened response to antiviral vaccines, poorer recovery from diseases, increased concentrations of circulating pro-inflammatory cytokines, and increased requirement for ICU admission and worse prognosis from COVID-19 infection across data from the UK, China, and USA, as Federica did mention in her presentation. So what about micronutrients? So micronutrients, we know for a fact with emerging evidence that suggests it in maintaining and improving immune function through several mechanisms, such as developing and maintenance of physical barriers through the skin and mucous membranes, production of antimicrobial proteins and antioxidant defense, recognition and elimination of pathogens through the activity of the immune cells and immune memory, and mediation of inflammatory processes. So a study was done on the key micronutrients with long-standing associations with respiratory tract infections, and it was found that vitamin A, C, D, E, selenium, and zinc had association with respiratory tract infections, but other micronutrients are needed for our immune system functions, such as vitamin B6, B12, B9, and minerals such as iron, copper, and magnesium. What about additional nutritional factors, such as probiotics? Probiotics are live bacteria and yeast living mainly in our gut. The good bacteria supports the immune function, controls inflammation, and creates some vitamins. So it's known that the gut microbiota plays a role in educating and regulating the immune system. And gut dysbiosis, which is a microbial imbalance, is a feature of disease, including many infectious diseases. So there is evidence that some bacteria like lactobacilli and bifidobacteria can modify the microbiota and modulate the immune response and protect against infections. However, we need more tests and more studies on its relating to COVID-19. Another nutritional factor is N3 fatty acids, which are omega-3 fats, which are found in cold water fish. So several trials of N3 fatty acids in patients with acute respiratory distress syndrome have been performed, and favorable effects were seen with decrease in ventilator days, decrease in new organ failures, decrease in length of stay in the ICU, and decreased mortality. But again, we need further investigations relating to COVID. So who are these high-risk groups? So in 2019, the UK National Diet and Nutritional Survey demonstrates a widespread inadequacy of status in vitamin D, A, folate, selenium across the population. It is important to note that this inadequacy may be higher in specific groups, and this data can be mirrored and widely across different countries as well. So our primary focus should be improving overall dietary diversity in the general population. But we need to recognize, as the study survey before suggests, that the dietary diversity is not enough. We need supplementation. So that's where another problem rises, where supplementation is not a replacement for our good dietary practice. So they need to go together. So we observe a crossover between people with the highest risks of micronutrient deficiency and those of highest risk of morbidity and mortality during COVID-19 pandemic. And that those groups are the elderly populations, people with obesity and related metabolic disease, and critically ill patients. So why? It might be due to reduced dietary intake, impaired nutrient absorption, or just overall bad quality of food that they've been eating. So the media attention was directed on 2 micronutrients, which was zinc and vitamin D, which I will be covering in the next slide. So zinc is involved in generating innate and acquired antiviral immune response, and deficient populations more likely to acquire pneumonia and viral infections. Clinical studies demonstrate that it's therapeutic to take zinc supplementation in viral infections like common cold and herpes. And zinc is recommended by the WHO as a first-line treatment for acute gastroenteritis. What the zinc does, it modulates the immune response and is a key factor in controlling excessive inflammatory reactions. It reduces the production of reactive oxygen species and cytokines, modulates regulatory T cell functions, and limits tissue damage in case of pneumonia and decreasing the risk of sepsis. However, not enough evidence to say if it can prevent or treat COVID-19. The famous vitamin D. So at the moment, no sufficient peer-reviewed evidence that vitamin D supplementation can be used to prevent or treat COVID-19. That doesn't mean it doesn't have a role in prevention or treatment of COVID-19. It's just that the effectiveness has not been tested yet. 10 micrograms a day, this was suggested by the UK government advice when the pandemic started and people were not going out as much and being exposed to sunlight. However, no more than 100 micrograms a day because there is potential harm in excessive use, such as hypercalcemia that can result in back pain and kidney problems from the calcium stones. So we do know that avoiding vitamin C deficiency is important for our health. For this reason, any role in avoiding diseases from deficiencies is supported. So obtaining sufficient vitamin D from food and moderate dose in high-risk groups especially is important. So how to identify malnutrition during COVID-19? The Malnutrition Universal Screening Tool said in ICU and critical care settings, patients with COVID-19 identified as high risk and requires that nutritional support when they're unable to consume anything orally more than 5 days. That's when tube feeding or parenteral feeding is used. That's why we should monitor the effectiveness of nutritional management in the ICU. Hospital wards and care homes, if it's not possible to obtain self-reported measures of weight and height, subjective criteria is used, also at home. So when there's the virtual consultations with your healthcare professional, again, if you can't obtain self-reported measures, subjective criteria is used, and I will be explaining what that is in the next slide. So patients and carers have a self-screening website that's available to find out more about how they can identify malnutrition themselves and how to get help. Advice should always be sought from your healthcare professional to investigate unintentional weight loss and nutritional concerns and manage the cause. So what is the subjective criteria? So according to BMI, you look at someone who's obviously wasting, getting thinner, or getting excessive fatter or increasing weight. Unplanned weight loss, so you can look at clothes, your jewelry, if they're getting some loose fitting. And if they have history of decreased food intake, reduced appetite, dysphagia with swallowing problems, and underlying physical disabilities that can cause weight loss. In COVID-19, infection is very likely to cause unplanned weight loss, which might be due to the effects of the disease, such as anorexia, breathlessness, impact of management options, sedation and ventilation, changes to taste and smell, and psychological factors such as anxiety. What about the acute disease, where a patient is acutely ill with COVID-19? He should unlikely have no nutritional intake for more than 5 days. So we use these combination of subjective criteria to estimate the malnutrition risk category and then receive an overall evaluation. So COVID patient 19s during and after hospitalization in the ICU. So a COVID-19 positive patient who is subject to hyperinflammatory condition associated with lung injury with the development of pneumonia is hospitalized in the intensive care unit and will be intubated for 48 hours. That's why they need adequate nutrition. So malnutrition in that situation can lead to sarcopenia, which is a decrease of muscle mass and worsening of the inflammatory state. This lengthens rehabilitation times with prolonged hospitalization, increased costs, and reduced turnover. So in cases of oral, enteral, and parenteral nutrition, it's only given according to the patient's condition in case of hyperinflammatory patient. And it's important to note that supplementation of amino acid did help lower inflammatory states and promote normal physiological recovery after the overexpression of pro-inflammatory molecules. So ICU and COVID-19. So European Society of Parenteral and Enteral Nutrition suggested 20 to 25 calories per kilogram at the first couple of hours of infection, and after a few days, they increase it to around 30 calories per kilogram. So novel therapies, what we need to investigate. So vitamin C, omega-3 fatty acids, and vitamin D has had previously multiple studies done and how it supports the immune system during acute respiratory distress syndrome. However, we need more investigation and more trials to see the link between all of these and COVID-19 patients. So considering the role of micronutrient status in COVID-19 and recovery may also warrant for further investigation. So a summary of what I just talked, we will go through every single column by itself. So COVID-19 is highly transmissible and potentially lethal. Strategies that can diminish respiratory infection risk and strengthen overall immunity are critical at this time. Immune function can be compromised and infection risk increased due to poor nutrition, insufficient dietary of key nutrients, and poor overall diet quality. Micronutrients are essential for good immune function. I have listed them before in this presentation, and it's found in a variety of foods that form a part of a balanced diet within national guidelines. Deficiencies in these micronutrients contribute to impaired immune function. So who are these high-risk individuals? Pregnant women, infants, toddlers, children, obese individuals, and critically ill patients. Why? Because when you're infected, you need to use more micronutrients. So due to their lack of good dietary intake or decreased intake of nutritional food and absorption, that might lead to the high risk. So in these groups specifically, a balanced diet and micronutrient supplementation is needed to support their immunity needs. So NetPro posted this on their website that shows the key nutrients that we need to support our immune system, with some studies on the right-hand side that show the role of each key nutrient. And then on the left-hand side, there's the food sources. So I'm going to focus, let's say, on selenium. Selenium can be taken from Brazil nuts, tuna, sardines, meat like turkey and beef, chicken, and eggs. And the study showed that it influenced innate and acquired immune system. So I highly recommend this table so you can look at it and see your food sources. These are my reference for today. And just a final note, COVID-19 is causing inevitable distress to all. Aside from the impact of the viral illness itself, prevention through social distancing and staying at home can affect both our moods and our feelings. This may cause loneliness, irritability, anxiety, and depression. So what can we do to help and enhance our physical and mental well-being? We can eat properly, sleep effectively, stay hydrated, stay active, and think positively. Thank you very much. And I will now open the panel to Professor Salman Rawaf and Professor Tawfik Khoja.
Thank you very much, Celine. Thank you very much, Dr. Amati, and thank you very much, Dr. Ayoub. I'm really grateful for absolutely superb three presentation. You tackled one of the most complex topics in our time, how to deal with nutrition during the pandemic. We know from clinical reports, from cases we deal with, that people suffer a lot in terms of nutrition during their illness and post-illness as well, in the period of recovery. And I think you truly tackled the subject very effectively. I'm sure Professor Khoja and I will shower you with some specific questions, some of it already received from our superb participant. And thank you very much for the people who participate. One question which actually come to our mind as an it's a general question. Everyone think about it. Healthy food is expensive. Healthy food is not commodity available for everyone. You can recommend as much as you can. I know that I buy healthy food. It's truly very expensive, you know. The fruit, the things which you recommend for us, your slide before the last, you illustrated a beautiful catalog of food, Celine. But I'm really not sure that every one of us can or able to find this. So this is question number one about affordability. The second question, that during the lockdown, everywhere in the world, we saw the businesses which are thriving are takeaway junk food, you know? So we have been, I mean, the government restricted all the restaurants, you know, even some of the access to a lot of things, you know, which we take it for guarantee in our normal life and living, but certainly they did not restrict anywhere in the world the takeaway food. And even now, Britain announced from midnight tonight, 2 o'clock actually, 1 o'clock Cairo time, 2 o'clock here, other countries. Yet they did not restrict. They closed all the restaurants, all the entertainment, all the bars, etc. But they did not restrict the junk food which people consume. I want to hear from you any answer, any comments about these two questions. Federica.
Thank you, Prof. I think I'd like to start by tackling your question on the affordability of healthy food. I think that we have quite a lot of evidence from several countries where they've done integrated food system interventions. And I think Dr. Ayoub touched on this in his presentation, where by introducing measures such as homestead farming and introducing measures whereby the governments actually support specific food systems, we can reduce the price of healthy foods. And by not subsidizing things such as palm oil and sugar, but subsidizing instead things such as vegetables and chicken farming, homestead farming to produce eggs for children, for example, we can improve access to healthy diets across the world. So I don't think that the sort of price of food necessarily has to be a prohibitive factor in improving diets. But I do agree with you, Prof, that there should be more of a ban, or at least a reduction in availability to processed foods. In fact, if we look at the US as an example, 71% of food that is consumed by the Americans is ultra processed, not even just processed, ultra processed. So there is certainly an issue with making ultra processed foods and unhealthy foods too available, too easy to attain, and not encouraging healthy foods instead. So I agree, that's a big issue.
Dr. Ayoub?
So thank you. This is really very important question. Here, we talk about food system, and we have to talk about at public and then at individual level. Maybe I'll start at public level. You know, now, as we know, that healthy diet is linked with the food supply. And it's the responsibility of the government to ensure that the public, they have access to healthy food. And here I want to give you an example. For example, sugar, oil. I saw in some of GCC countries, the government subsidized sugar, subsidized palm oil. So what is very simple is, instead to subsidize sugar or palm oil, subsidize pulses, which is very cheap, affordable, or fruits and vegetables, especially for low-income countries, or maybe healthy meals in the schools. This is number one. Number two, we talk about micronutrient deficiencies. We know now the public, they might not have access to the fruits and vegetables, especially under the COVID-19. But I could maybe fortify food, for example, wheat flour, I added premix, which includes the essential micronutrients, or palm oil, I added vitamin A, D, or B vitamins, I can really enrich it. This is a kind of the safety net program that government could do it, or could collaborate even with the private sector, because it costs only $1 per 1 metric ton. Now, we talk about individuals. Individuals, I believe that, and I saw it by myself, even in poor countries, for example, in Egypt, even the poor people, they have still access to buy green leafy vegetables, which is very cheap. Jarjir, they can buy, for example, tomato. It's not expensive that much, but they also have access to pulses, like broad beans. In Jordan, same thing. So I mean, you can still, and there is seasonal always of vegetables and seasonal fruits. Some of these seasonal locally produced, they are usually cheaper than the one imported. But anyway, I believe that, for example, for school meals or school feeding program, we could really introduce a locally product which is accessible, cheap, like dates, for example. Dates is very cheap, is high in vitamins, minerals, available in all our regions in good prices. Maybe the government could subsidize it. I mean, this linked with advocacy, linked with communication campaign. But initially, and we have really good examples in some schools, they have date bars which include dates, and also they add micronutrients like iron. They add, in Jordan, for example, they add 10 micronutrients in wheat flour. That course, that's it.
Yeah, Dr. Ayoub, you said something about school meal, and I fully agree with you. And I'm sure you heard, or indeed you read, about the debate in the United Kingdom in terms of supplying school meals during holidays, because during the term, any term, all the terms, there are actually food supplied freely to the children in our schools in the United Kingdom, but not the case actually during holidays, all right? So there are a lot of huge public debate, a lot of pediatricians, people in child health and public health, raise a lot of issue with government that schools should provide meals. My question, in the Arab world, Celine, don't worry, I'll come to you in a minute. In the Arab world, do we have actually food supplied freely for those who need it in our schools in the 22 Arab countries or not?
In fact, unfortunately, it's only the program supported by WFP, World Food Program, through school feeding program, or some poor communities in Egypt, and they only provide milk, sterilized milk with dates bars, but not hot meals. So I don't think we have in our region proper school feeding program as we are aiming for. Only they have a special program supported by WFP or by government for poor community, and the idea is not linked with healthy diet sometimes. It is just to meet the needs of the people. So I'm sorry to say that this is the situation now.
That's very interesting. Because you mentioned it, and I'm a bit surprised. It would be nice to hear from participant, from the member of the Arab Public Health Associations and all colleagues who is with us today, if they have experience in the region of any school meals provided in their countries. We will be very proud to share it with everyone. Celine, go back to your question, to the questions which I raised. I'm really, again, talking about the junk food. And in particular, Ayoub talked about the salt and the sugar, etc. I mean, if I order a pizza now, I know for sure that I will raise my blood pressure at least 10 milligrams or something like that, okay? It will go up by 130, 40, something like that. So what do you think?
So Federica and Dr. Ayoub did mention a lot about what in the future we should do, but I'm talking about now. Each person, if they have the will to be healthy, they can be healthy. They need to learn about the food they're eating, what they're going out to buy. They need to prioritize that a bit. Other than that, it's just a healthy meal. So if you're going to buy from a junk food restaurant, know how to balance it with something else. Know what's in it, know what micronutrients are in it, know what you need. So it's all about the will of the person. If he's willing to be healthy, he can be healthy.
So it is the onus on us.
Yeah.
Healthy,
A tiny bit.
even if we don't have money to buy the.
It's not about money. It's about prioritizing what you're gonna eat. So how much does it cost to actually buy some lettuce and including it with your protein intake, with what you have already there? If you're gonna eat a pizza, eat 1 slice or eat 2 slices with that lettuce there. You can prioritize what you're eating.
Okay, good point. Professor Khoja.
Thank you so much, Professor Salman. This is great to come back to you and to my colleagues. I am really impressed by the presentations. It was an excellent one. So much I learned from the 3 presentation eminent speakers. Thank you, Professor Salman, for all of these, your efforts. It is well recognized now everywhere, not in the Arab region, but also globally. This is great. I have actually 4 questions. So I'll start with Celine and Dr. Ayoub, and I'll come back the other 3 questions for the 3 of you. Dr. Ayoub, you mentioned about nutrition equity, access to high quality food. And Celine, Dr. Celine mentioned about the issues of risk groups and macronutrients. I really wonder, I conduct so many webinars in this area about healthy lifestyle and proper nutrition and so on and so forth. I really could not come out what about the proper measures should health system and the public health should apply for vulnerable groups, high risk groups, older adults, patients with NCDs, pregnant ladies, lactated ladies, and so on, mothers. I feel that we are lacking a lot in this area. Even if you see the strategy by WHO is what does not highlight in depth on this area. So I want both of you to give me your impression of why we are lacking in this area. Thank you so much.
Do you want me to start?
If you don't mind, please. You have the floor.
Okay. Well, first of all, it's nice really seeing you, Dr. Khoja. You are a pioneer in the region, and you are a friend and a brother. And of course, you are involved heavily in the region. I think, in my opinion, integration of a nutrition through health system, it needs really political will and understanding to the concept of the importance of a nutrition. And I can see now there is a changes. Although this, we used to have a big challenge before. Now there is a lot of changes. I can give you example. In Saudi Arabia, for example. Saudi Arabia, they added sin taxes on the soft drink. There is a sharp reduction on the production of soft drinks. They are now eliminating or banning trans fatty acid. And it is a big decision, the first country really to go for this. They are promoting healthy food in schools. There is very good school health campaign. Also, if you look at salt reduction, they are really sponsoring. Now, FDA, they start to talk about regulation. They start to talk about standards. Even today, there is a big meeting on food standards. So I think it linked to the political will, the knowledge of the policymakers and the institutions itself. It has, for example, I can tell you in Pakistan, it's a poor country, they have been challenged. There is a change now because the Prime Minister realized that nutrition is essential for development. So now they have high-level committee. There's 4 or 5 ministers, member of those committee. They are investing in nutrition. They are putting resources. They are also integrating nutrition through primary health care. So, for example, in the old days, they just take supplementation as such, but now there is a change. Even if you go to any primary health care in GCC, you see there is a dietitian there. There is growth monitoring. Same thing in Jordan. Nowadays, they are integrated in nutrition through primary health care. So there is a change, but this is linked with political will and also sometimes the resources.
Thank you. Celine?
Perfect. I'm just going to add on that. It depends as well on the healthcare professionals that are out there, and how much the physicians are going to help according to what the information we already have about micronutrient deficiency is a lot. So we can't ignore the evidence that we have that micronutrient deficiencies does lead to a lot of problems. And it's important for future research as well to support this. So now we have technology, now we have available data from the population and patients that can be able to give us more evidence to implement this on every level.
Thank you. I have another one, Dr. Amati, and also again, Dr. Ayoub. Let me say it and then we'll come to the question. As we know that COVID-19, the pandemic imposed a new set of challenges for the individual to maintain a healthy diet. And it has been mentioned very clearly by Professor Salman Rawaf. First, the state of lockdown, stay at home, self-isolation, social distancing, irregular eating, irregular eating pattern, and frequent snacking with high calorie intake, and so on, and increased risk of obesity. For me, as a public health, now we are in a public health society, as a public health specialist or consultant, how can I balance the equation of a healthy diet with this a lot of risk factor? I mentioned lockdown, stay at home, social isolation, snacks, and so on and so on. I feel, I don't know, is there any magic solution for this? Really, I am suffering. I gain now 5 kilograms. I am not Salman Rawaf. Salman Rawaf, he is a sport person. Me, I gain 5 kilograms. This is during the 6 and all my family are gaining weight. So how can we balance the equation at a personal level, community level, national level?
I'll have an attempt at answering that. I wish I had a magic wand, but I think we can all sympathize with you, Prof. Khoja. It's I think a lot of us have put on weight during lockdown, but the important things to look at are the positives. So here in the UK, for example, we maintained 1 hour for physical exercise, even in the strictest lockdown conditions. So I think it's important that we emphasize the absolute need of people who are able to get outside of their properties to exercise every day as their way of getting out of the house, first of all, preferably in a green space if they have one nearby, and to make sure they move every day. It doesn't have to be exercise in the form of a gym, but physical movement is absolutely key to good health, as we all know. Secondly, I think in some countries better than here, for example, South Korea, they did a very good job of providing healthy food packages to those who were either confirmed COVID cases or who were at risk of malnutrition. So the elderly, people living alone, people who had a lower income. I think that's a very good public health initiative. So if we could use some of the money that is being put for COVID to actually sustain the nutrition of those vulnerable groups by providing healthy food packages, especially if, for instance, like repurposed restaurant food, which is now not being used, just really making the value chain, the food value chain work to help these people would be important. Now, as education is a big side of this as well, and as Celine touched on earlier, mental health really impacts the food you consume. So boredom, anxiety, depression, loneliness all impact what we consume, and what we consume in turn impacts that back. So we know that consuming certain foods increases anxiety, but we go on consuming them because we're anxious. So I think really informing the public and reinforcing the importance of good diets and physical activity, especially now in the context of COVID, especially to reduce your risk of infection and especially to reduce your risk of complications, is one way of tackling this. So we have to educate the public, make sure that people make the right choices, but also give them the opportunity to make the right choices. I have to respectfully disagree with Celine that it isn't just down to personal choice. If we do not have the context within which someone can choose to eat healthily, then they cannot do it. In certain areas of London, for instance, there are food deserts
where there is no access to fresh fruit and vegetables, there is only takeaways. And those are the places where we have to really target our efforts to make sure that we provide these families and these individuals, the elderly and those with long-term health conditions, with the right food to eat.
That's great. Thank you very much. I mean, this is really an important question from Professor Khoja in terms of how we control ourselves. And this is linked to a few questions from Wissam Jalad, and from Chido, and from Basim Rafiah, if I'm pronouncing it correctly. And before I come to this, what is called home cooking during COVID, because there are a lot of questions related to that. There is a question on what timing, what is the right time to take vitamin D? Actually, 2 weeks ago, a microbiologist raised this question with us about vitamin D, and she was talking about a lot of vitamin D will possibly prevent COVID infection, or indeed could minimize the clinical picture. Any idea, a question open to the three of you, Ayoub, when should I take vitamin D? Or shall I go naked in my garden, exposed to the sun? Which one is better?
Well, initially, I want to mention one important point. We just published a paper about vitamin D. There is a misunderstanding about insufficiency and deficiency. And this created a lot of really a chronic problem among health professionals and among the people. And every time I talk to people, even you find medical doctors, they say 70% of the people are suffering from vitamin D deficiency. This is not true. So we have first to identify insufficiency and deficiency. Now, if you go, and the best thing is for people to go and do lab analysis. And even the lab analysis, they have to go for the levels recommended by, not by WHO, has not yet came up with recommendation, by the way, on vitamin D, only I think CDC. So, and here I would like to highlight that we did for sure encourage diet diversification and exposure to sun. It costs nothing. If you exposure to the sun for 10 minutes, 15 minutes is enough, and it's cheap. While supplementation, and I saw people are taking supplementation in huge quantity, they have no knowledge, and they go to the pharmacist and take. So I have here to, since we talk to the public, and we have to differentiate between really insufficiency and deficiency. And my advice to the people, go and do a test and consult dietitian. Don't even the medical doctor, if he's not specialized, you have to go for clinical dietitian and seek his advice.
Deficiency is very common, Dr. Ayoub, very common in the Middle East.
Yes.
Vitamin D, a sort of anemia. I mean, I recall in Iran, in one of my visits, these were two common problems in the Middle East. I mean, we have some data from other parts of the Middle East without mentioning countries by name, but certainly it's a major problem. Exposure to the sun, as you know, a lot of people, they don't want to expose themselves, simply to be darker, And while exactly the opposite in the West, we pay money to be darker, a bit, and a shade darker. It's a catch-22. Celine, any idea when the right time to take vitamin D?
Yes, definitely. So we need to remember that the fat-soluble vitamins are A, D, E, K. So it's important to take that supplementation with a big meal. So your main meal, so your breakfast, you can take that vitamin D because it's fat-soluble, and drives the absorption rate like ×2 when you eat it with a full meal. So that's it, because vitamin C and B are water soluble, so they're not stored in your body. So drinking it with water and it just goes, so excessive intake of vitamin C and vitamin B would just go right through you and cause diarrhea if it's excessive. But vitamin D might lead to a lot of health problems. I think that's what Dr. Ayoub meant. So whoever needs to...
You think vitamin D, if people take a lot of vitamin D, they will have problem. What are these problems? The kidney problem?
Yeah, hypercalcemia. So that's the kidney, the stones, the calcium stones that might end up with back problems, kidney problems. Yeah, from excessive.
Which is mainly if you take vitamin D and you have develop kidney pain, you have a problem. Be careful about that.
Exactly. So yeah.
Okay, but elderly people, Celine, and I want whether Professor Khoja, Ayoub, and Federica will contribute to this as well. But elderly people, they do need vitamin D supplement. Vitamin D supplement is important, to prevent osteoporosis, to softness of bones, because the absorption is not that good in that age group, but also exposure to sun is tend to be not very high. What do you think about this?
Yeah, especially that's what I mentioned in the high risk groups, that they need supplementation of
We don't want to call the elderly high risk group. Call them, the elders.
Okay, the elders. So yeah, low levels of vitamin D result in fatigue, back pain as well, depression, impaired wound healing, bad immune response, bone loss, hair loss as well. So yeah, so definitely the elderly population does need supplementation with good dietary intake.
This is, you see, Professor Khoja, this is how the very young people look at us. We are a risk group.
In a few years they will become like us.
Yeah. Let me come. Forget the dinosaurs now. Let me come to the interesting questions about. This is from Wasan. Wasan saying that actually we are during COVID-19 era. We are eating healthy food more than other time, simply because we are depending mainly on food which are cooked at home, prepared at home. Is that true?
Well, I can, from my experience, I passed through this experience, even my family. Yes, it's true. Because people, especially young people, they order food from restaurants but because of the lockdown, people start cook at home. Not only this, I saw young, my kids, they go to the kitchen and they cook by themselves, which good experience. I think it has both sides, yes.
So you have cooking classes at home?
Yes, exactly. We participated and it went very well, really. And we maintain our weight normal.
Celine, linked to that, is there any, and Chido was talking about it, is anything in terms of home cooking and addressing, what type of health education people in lockdown, and as I said, tonight we will be in lockdown, what type of education, health education I need to improve the quality of my home cooking? And thank you, Chido, for the question.
So yeah, so there's no point of these superfoods that so normally the media covers mostly, that superfoods and that excessive supplementation that Dr. Ayoub was talking about. So what we need is just a healthy, balanced diet, variety of foods out there. There's full range of proteins and where you can get your vitamins and minerals from, your fibers that support your microbiome, and the good fat. So mainly a plant-based diet with your proteins and your fibers as well. That would be a good way to start your cooking.
Yeah. Federica?
Yeah, I think that the best way to approach, I think actually just to go back to the original question, the data does show that the numbers of people spending their money on fresh groceries. And actually companies such as Ocado, Waitrose, Marks and Spencer, Sainsbury's Delivery, all these delivery services, including farm deliveries, have really shot up in the UK at least. So people are cooking more at home, which is great. I think in terms of health education and nutrition education, what Celine said, just aim for plant-based diet with some key nutrients from things like eggs, oily fish, nuts, legumes, and it just really now we have more time, we can explore different cuisines and try and make things from scratch using mostly whole foods. I think as long as we're using whole foods, it's quite hard to go wrong.
But we are, if we are at home, Federica, we are nibbling all the time. I mean, Professor Khoja is a very good example.
I'll kill you.
Yeah, I think that if you're a nibbler, then my personal recommendation is make some hummus, keep some carrot sticks at hand, have some almonds at hand, and just try and make your foods that you snack on, make the options slightly healthier ones. If I'm the same, if I have a packet of biscuits at home, then obviously I'll reach for them, but try not to buy biscuits in the first place, and then you've really limited yourself to carrot sticks with hummus.
I think we need to record a day in the life of people during the lockdown, especially focusing on the kitchen. I know from our experience here at home, we are sitting most of the time actually in the kitchen, where we have place to sit, and even our TV is in the kitchen. So
Doctor,
now the kitchen is becoming large and big space with a lot of facilities in it. Sorry, Professor Khoja, you want to come in?
If you allow me to, I would like to ask another question, if time's allow.
Yeah.
I go. Okay, thank you very much.
Yeah,
actually, this is. Thank you, Professor Ayoub. You said that I am a decision maker in the past. Okay, I was responsible for setting the strategy in the Gulf and also policies. I would like from all of you, actually, even Professor Rawaf, because he is a pioneer in setting the policies, especially for public health, to highlight, this is two questions, but they are going together. What are the most important determinants for putting strategic national policy for nutrition during pandemics? COVID-19 is an example. Now we are almost 7 or 8 months suffering from this COVID. So this is, what are the most important determinants? The other question, which is come with this one, there was a lot of studies and recommendation. While I was preparing for this webinar, the conference, I saw so many studies published in, especially in Western leading journal, and regarding discussing of the framework as a national framework for security, food security, and proper nutrition. And they speak about multi-level model action. When I read about this one, I see this concept or this model is far away from the region. Maybe apply in some countries like Saudi Arabia, as you mentioned, to some extent. But I would like to, from all of you, I mean, to highlight on the most important determinants, issues regarding putting the strategic policy for proper nutrition at the pandemic, and what about the approach which is called multi-level model approach for action for nutrition during pandemic? So this is the question.
Good two questions. Ayoub?
Thank you. This is really very important question. And here, if you want to address this issue, you have to look at food system as a whole. In the old days, we talk about food security, access of people, affordable. But now we should look at the food system as a whole. And food system, they look at 3 levels: at food supply, food environment, and also they look at knowledge and advocacy to the public. So it has to be really comprehensive approach. And also this approach should be supported or developed with all sectors, because if you just give the responsibility to Ministry of Health, we are doing a big mistake. Ministry of Health is true, responsible on prevention, but in our region, they have been bombarded with curative services, hospitals, and the minister or his team, they are busy just how to accommodate the COVID-19. So I think we need to involve other sectors who can really take full responsibility, like agriculture, food supply, trade, industry. As we said earlier, what you need is just one decision from Minister of Trade to block all these harmful products. And in our region, for example, we import 70 or 80% of the food is imported in our region. So if we import 70 or 80%, what I need, decision from the minister to ban trans fatty acid, to reduce the level of salt in the cat food, in the restaurant chain, to promote in front of food packaging, to advocate the people. So I agree with you. And when we talk about 3 levels, you need at policy level, then you need at community level, and you need at individual level. And the good news with this pandemic, we developed some material in WHO. I can tell you, the people are really communicating by through the Facebook, through other communication means. And I can tell you, people now, they know about healthy diet. What's healthy diet? There's a lot of communication materials. And this is the opportunity to engage more the public on healthy diet. And also, if you look at obesity and diabetes in our region, I can tell you something which people don't know. Maybe rice and wheat flour is one of the main causes of obesity, in fact.
Could be.
People are consuming a huge amount of rice and bread. Even they eat rice with bread. So this is really clear. So I mean, we need to really look at the government. We need to review our subsidy program. And Dr. Khoja, what we need really, something to work on food system. I think Oman started some work like this. Thank you.
So we have to declare war against bread and rice. Excellent. You need to remember, a lot of people actually depend on rice and bread, especially bread, because this is, for many people, is the main meal and the only meal sometimes. So we need to be very careful about that. But it's a good point. It's a very, very valid point.
Doctor, we can advocate to reduce the quantity.
Yeah. I mean, we have a few other questions, but my immediate response to you, Professor Khoja, is that actually, since COVID-19 with us about 9 months ago, the whole focus of the scientific community, policymaker, were on issues of the virus, understanding the virus. Until today, we didn't understand this virus fully. Secondly, on the issues of the epidemiology and how really to suppress the pandemic, and in particular, minimize the transmission. The third issue on a clinical aspect of the disease and how to protect our hospital, how to manage cases within hospital, et cetera, et cetera. The human aspect in terms of nutrition, mental health, social cohesion, the issues of the impact on families, child abuse, partner abuse, drug abuse, alcohol abuse. In 2 weeks' time, we have hopefully a webinar with some prominent leaders from United States and the WHO on addiction. We did not focus on these. I'm not aware of any policy makers gave these issues priority. Some people mentioned it. I mean, even Ayoub said quite rightly that WHO were not very much specific in their recommendation about diet, etc. We have a nice question from BH, I don't know, abbreviation used here. Would you say there are any superfood, I like that term superfood, or even supplement that you recommend to take during these times? Okay. Federica,
Well,
this message to you. Do you recommend any food?
As I said, if you're a healthy individual with a well-balanced diet, then there isn't anything called superfoods or supplementations that you do need, other than what the UK government recommended, which is the vitamin D, because we're not seeing sunlight. But other than that, no, just a healthy, balanced diet that should cover the whole variety of foods. And use the table that I mentioned before from NetPro, and yeah, that should cover all the supplementations.
I mean, what about a superfood, which is the color of it is green, very low in salt, very low in sugar, and very low in fat? What do you think about that?
That's absolutely.
The question was to you, actually.
No, as Celine said, there is no such thing as a superfood. Okay. I'm pretty sure the best thing to do is aim for a super mix of all foods, specifically fruits and vegetables.
Perfect.
Okay. Food from Professor Nermeen Ahmed from the High Institute of Public Health in Alexandria, a major public health source for us, and food served at restaurants. Could it be a source of infection of COVID-19 if it's not properly handled or heated or prepared? Anyone?
My understanding of the transmission rates in restaurants from the UK is that the transmission isn't happening from the foods being served, but rather from being in a poorly ventilated room. So ventilation seems to be the biggest factor in COVID transmission in restaurants. And so aside from, unless someone is really sneezing on your food and then you're eating it, it's more likely to be a problem with other diners, which may be infected but asymptomatic, who essentially spread aerosols around the room, and their rooms aren't ventilated, especially in winter. Pubs, bars, restaurants don't tend to have all their windows open and doors open, and that's a real problem.
We have four minutes left, and Ibrahim Bani asking, what's about food safety during COVID pandemic? Any specific policies or recommendation for public and individuals about food safety?
Yes, there is a clear policy and guidelines available in WHO website. You can share it. It's if you go to WHO, there is with pandemic, there is clear guidelines on food safety and nutrition, and there's a question and answers. And of course, the message, as you said, we have to consider the food hygiene during the procurement, purchasing, and serving. And of course, the risk comes from the people, the individual who are infected if they sneeze. So we have to make sure that the people are protect themselves. They are wearing the masks. They are also wearing gloves during the food preparation, handling, washing, and also the restaurant should be clean. So there's clear guidelines. So it's like what the practice is at home or at the restaurant, the same.
And washing,
testing.
When you bring things at home, washing the all materials, whether it's fruit or even packed things, you have to really wash it the proper way.
Exactly. Cooked food, he can use the wave and the microwave in case if it's already cooked food, whatever he can maybe use the microwave to kill any microbes.
How do you know I was asking a question about that? Because there is a question about the microwave. Will the microwave kill COVID-19 virus? Dr. Ayoub, Federica?
Very high temperatures are disruptive. I'm not aware of microwave itself, but I understand that cooking food at very high temperatures, so 200 degrees or more, is disruptive. So if you microwave it for long enough until it's really, really hot, then it might be helpful.
But it's still, even if you put things in microwave, you find some small island here or there, the food will remain cold.
Yes,
Especially
yeah,
if it's a microwave, it's not commercial one.
It's not really the right way, but of course it depends on the duration and the temperature and what kind of use is it. If it's warming, then it's not practical. But if it's cooking deep, yes.
So,
I also wanted to.
There is theoretical possibility here that the transmission could happen using the microwave.
I just wanted to add, Prof, on the food safety for maternal, infant, young child feeding. It's really key that we remind mothers that it's safe to breastfeed in this time. There was a study published that looked at the advertising of formula infant milk in the UK, and they really targeted those who were worried about COVID. So we've got to be really mindful to remind mothers that breastfeeding is the safest.
And that's a criminal.
I know it is actually, yeah.
Well, thank you very much indeed on behalf of all colleagues at the Arab Public Health Association, Professor Khoja, and I would like to thank Celine for her leadership. Thank you very much for her superb presentation and responses. For Dr. Ayoub, thank you very much indeed. It's a pleasure seeing you again and again, and we look forward for more contacts. In 2 weeks' time, our session will be on addiction. I invited a colleague from United States and from Britain, two eminent professors in the field. There are a lot of pressure on Professor Khoja and me to continue holding this webinar on a weekly basis. We will do our best. I know now we are entering the second wave. Many countries are already in the middle of the second wave, and possibly we will go on the third wave. So there is a demand on us to hold it on a weekly basis. We are studying that, and we will never let you down. Thank you very much indeed. Thank you, and good night, everyone.
Thank you very much. Nice meeting you all. Thank you. Bye.
All the best. Bye-bye. Allah bless you all.